Well, thank you so much to everyone for being here. And thank you, Dr. Demos, and to the University of Texas at Arlington for hosting this event. And a huge thank you to James Hollis for his help in organizing the event. My name is Marissa Evans. I'm the Health and Human Services Policy Reporter with the Texas Tribune in Austin. And this is such a personal and important topic, and we are so thrilled you are here sharing your time with us today, and we hope this is going to be a very lively discussion. But first, I have some more reading to do. Thank you to Blue Cross and Blue Shield of Texas for presenting the second event of a year-long three-part series on healthcare. And thank you to Pearson for supporting this event and to the Fort Worth Star-Telegram for their media support. Though donors and corporate sponsors underwrite our events, they play no role in determining the content, panelists, or line of questioning. The Texas Tribune is a nonprofit, nonpartisan digital news organization covering statewide politics and public policy issues in Texas, and we are supported by members just like you. To become a Texas Tribune member or to learn more about what we do, visit texastribune.org/give. I will remind the audience to please silence your cell phones, and if you want to tweet with us, you can use the hashtag #TTEvents. The event will last until 1 p.m. and will include a 15 to 20 minute period of Q&A at the end. So at this time, I'd like to introduce my panelists. Beside me, I have State Representative J.D. Sheffield, Republican from Gatesville, who's Vice Chair of the House Public Health Committee and member of the House Select Committee on Opioids and Substance Abuse. Next to him is Dr. Stephanie Jones, Assistant Professor of Anesthesiology and Pain Management at UT Southwestern Medical Center. And next to her, State Rep. Garnett Coleman, a Democrat from Houston, member of the House Public Health Committee and the House Select Committee on Opioids and Substance Abuse. Welcome, everybody. So we've been having a lot of conversations in the last, I would argue, several years now about opioids and substance abuse, and we have healthcare professionals on this panel, we have legislators on this panel. So in thinking about keeping those things in mind, what is something that you thought you knew about substance abuse or opioids that you were wrong about? I'll start with you. That's just the first question.
Well, being a family practice doctor for 25 years, I've seen this from residency when we were trained that these were highly addictive, be very careful, until where we are now. And what I have been amazed to learn is how much of this is also hand in glove with our criminal system and the amount it plays on both sides there. So I was surprised to learn that the most.
What I've seen in my career is that earlier we felt in like the late 90s, early 2000s, that if a patient had pain, they were very low risk for developing opioid use disorder when prescribed these medications. And I think over the last 10 to 15 years, we have really seen that that's not the case. So we have got ourselves in a situation where prescribing high amounts of opioids has helped to contribute to the opioid crisis and not realizing the risk of opioid abuse in patients when prescribed these medications.
I think what you would call the migration of opioids in pain treatment into the area of illicit drugs that has led us into a crisis. In the fact that, just as you said, Doctor, that other physicians have said they did not expect there to be this crisis of addiction that came from prescribed medications. And with that, the introduction of serious pain medications like fentanyl, not just your typical, OxyContins of the world, into the stream of abused drugs out on the street, particularly combined with heroin. Those are surprising things to me for various reasons.
Okay. Dr. Jones, you talked about your time so far as a doctor and what you've seen. So, just for the audience, people watching the live stream, talk to me about who is most at risk of opioid misuse and how is that impacting how you go about managing their pain?
So first off, we must treat everyone the same, right? And realize and use universal precautions, the same way we do for contracting disease. Assume, that you must be careful with any bloodborne pathogen that you can get a disease from anyone, and just assume. So we can't identify who's actually at risk. So there are certain things that there are certain tools that we can use to look for a patient that might be at higher risk for developing opioid misuse. But we cannot predict who will develop opioid use disorder after being exposed to these medications. So there are certain things or certain validated tools that we use to identify those that may be at risk. Opioid risk tool, the SOAP measure, these are tools. So people that have a history of opioid use disorder, then obviously we expose them to these medications again. They're at higher risk for relapse and recidivism. Patients that have history of other substance use disorders such as alcoholism or utilizing other illicit substances. So these are some of the things that we look for. These are the things that can put patients at higher risk. Younger age younger than 45. In that gap between 16 and 45, these patients are at higher risk for opioid misuse. So those are some of the things that can put patients at higher risk, but I want to clarify and emphasize that that's part of what's got us into this situation is we cannot identify who will go on to develop opioid use disorder.
For our legislators on the panel, there's the big "how did we get here" question. How did Texas specifically get here? And wondering, Representative Coleman, if you want to weigh in on that.
Well, we got here with the rest of the country, and I think from what we heard in the Select Committee, and Dr. Sheffield, I think, is that just what you've said, Doctor, that people did not expect the use of drugs like OxyContin, hydrocodone, and others to lead to addiction and the free prescribing of those medications thinking they were safe. Not that somebody said, oh, we're just going to give everybody an opioid. Has really led us into a nationwide challenge. And then you take those same drugs, mix them with alcohol, and overprescribing, meaning, in this case, meaning giving 30-day worth of prescription and then often refilling that 30 days to getting to 60 days. And then doctor shopping led to addiction over a long term. And then, of course, those individuals shopping the illegal market. So we've been having this challenge for about 15 years. I do remember on a panel or in front of the Select Committee, Dr. Sheffield, that one of the physicians who came out of Baylor College of Medicine being told that everything was fine. It was safe. There was not a problem, and people followed through with that kind of prescribing, thinking that they were doing no harm. So I think that's what got us to where we are. It obviously was a problem I think in addition to that was this kind of fourth or fifth vital sign, pain. And if you have pain of a certain amount, then one of the objectives of the hospital or the physician was to not have any pain. So that meant a more likely prescribing of a perceived to be safe drug, which, in hindsight for me, morphine was never considered to be safe, and how a pharmaceutical company could have made it seem as if all of a sudden the same derivative was safe and not addictive, in hindsight probably was overlooked.
I'll tag on to what Chairman Coleman said. I remember being a resident in family medicine and being told in residency, be careful prescribing these medications, they're addictive. use only as little as possible, and we'd rather you err on the side of caution than contribute to a patient's further medical problems. And then I remember the pharmaceutical salesman, we call them drug reps in the business, so you'll probably hear me use that phrase, coming through and saying, with this medication, here's this study that says if used properly, addiction potential is very, very, very low. Okay, well, you had the study, we had the drug there, so here we go. But what fueled the fire was this pain being used as the fifth vital sign. Now, I have to give a little background into that. 4 vital signs: pulse, blood pressure, temperature, respiratory rate. Those are measured, but you can't measure pain. So all about the same time, the first years of practice, here comes the 0 to 10 pain scale. And that is so subjective, and it varies from patient to patient. Some of the smallest frame people can withstand a lot of pain. Some of the biggest guys I've taken care of can't even take a small cut. So when you're trying to get this pain level less or equal to 4 on a scale of 1 to 10, and then probably a lot of you have seen the smiley face. You know, the smiley face turned down in a lot of pain, turned up, feeling a whole lot better. Well, now how this played into the business of medicine, Joint Commission Accreditation Hospital Organization, called JCO for short, they accredit hospitals. You want to be accredited. To be unaccredited hospital is a very bad thing. Well, they start using these Press-Ganey scores on how well patients report their pain was treated under your care while you're in the hospital. So you can imagine when the hospital gets these patient reports that Dr. Sheffield did not take care of my pain well and I suffered, and then the hospital says, Dr. Sheffield, your patients say you're not taking care of the pain. That makes us look bad in front of JCO. What are you going to do about it? Well, you can understand what doctors did about it, because we needed to be accredited, and it depended on those very subjective issues. So that's put a lot of fuel on the fire.
Okay. Good stuff. So in thinking about everything we all just talked about, who is getting left behind in these conversations? I mean, we have all these people in the room, obviously, who are very engaged on this issue, but who are we leaving behind as patients? Who are we leaving behind in communities when it comes to talking about substance abuse, opioid misuse? Whoever wants to go first on that one.
You're from Harris County, and we have heard that the largest mental health facility in the state of Texas, Harris County Jail.
Harris County Jail.
Okay. You have such a strong connection that I wasn't aware of between substance use disorders and mental health issues, and these folks ending up in our prison system, not getting the proper treatment either in the prison or when first out of prison, and so they cycle.
That's correct.
Back and forth.
Right.
That's the main group, I think, that we're leaving behind a lot right now.
Go ahead.
Well, I think it's important to engage the patients, especially those with chronic pain, because a lot of these patients were started on opioid therapy, and now we're in a situation where we're trying to address the opioid epidemic. We're cutting back on prescribing of opioids, and patients that have been on these long-term therapies are needing alternatives. They are not able to be prescribed medications that they may have felt were being helpful to them, and so I think it's really important to engage patients with chronic pain that have been on these therapies, because we need a solution moving forward to how to safely prescribe these opioids when they are indicated.
Well, in following up on both of the comments, one, you're right, the mental health of people across the country is one of the reasons why we're seeing a growth in addiction, period. Opioids in particular, and rural patients in particular within that group. If you want to take it from a social perspective, when we sometimes use rural as a euphemism for Anglo or for white. Because, quite frankly, from the prescription standpoint, the overprescribing or the comfort with prescribing was probably more pronounced among white patients. As a matter of fact, what was shown was that patients of color, particularly black patients, were less prescribed when it came to more efficacious pain medications, which would have included opioids. So from that perspective, I guess being black was a good thing, huh? Because you didn't get you got the strong ibuprofen instead of the opioids. But that created an even greater challenge, because in a place where there was a downturn in the economy, just a certain malaise that existed, the addiction just fed on itself. And in our rural areas in the country, that's certainly the case. We also have a problem in other addictions, and I think it's a good time to bring that up. People who are addicted are addicted. If they can't find opioids, they're going to find crack. If they can't find crack, they're going to find methamphetamine. And when we talk about substance use disorder, we really need to talk about all of it as we move forward, and make sure that whatever funds or in our criminal justice system, whatever treatment we can do as people come in and out, that we focus on all of those highly addicted substances that we have out there, and things like Klonopin or other substances. But we can't leave out the fact that there are people in great pain. I met with the folks from Texas Children's about children with sickle cell and the amount of pain that they experience, and making sure that we have these alternatives, or continue to be able to use opioid painkillers in a way that effective but not addictive. And I think that's important. One last piece, what you said, there was a friend of mine who was addicted to opioid-based painkillers and then had an accident and really needed strong medications, and quite frankly, there was a dilemma as to whether or not that individual could be treated and have their pain relieved without going back into a full-blown addiction to those same painkillers.
I might tag on to
ahead.
this. He mentioned rural. Our district is 8 counties rural, and just as he said, there was a time several years back when the rural economy took a hit in our area, and one of the attorneys in the area we were speaking with said, right after the economy took that hit, it's when all the meth labs started, because they could get all the instructions they needed off the internet. They could make the stuff in their own home or shelter, and that's when there was a clear connection between an economic downturn and the start of another substance abuse problem.
Well, keeping that in mind, we've mentioned meth, we've mentioned heroin, so drugs that are illegal to use. So, how do we keep the conversation around addiction as opposed, even if it is illegal drugs?
Fortunately, that's happening to some degree. If we go back in time, and some of you all may be too young to remember the 80s. I'm not anymore. So anyway, but crack cocaine was treated very differently.
Right.
It was treated as a criminal justice problem. We even went to war against it. And I don't believe we won that war. As a matter of fact, most people would say we lost it, in that we probably, if we were approaching it the way we're approaching drug addiction now as a medical problem, then we would be in better shape. Fortunately, criminal justice reform on the national and state level, looking at particularly mandatory minimums and sentencing, is going to help that. And that we're not moving in that same direction with opioids, or we're looking at meth and crack cocaine differently in terms of dealing with that, with those drugs as a problem, which is a good thing. Because if we really looked at it, and Dr. Sheffield, you said it, if we look at co-occurring disorders, substance abuse, and mental health, people have been self-medicating for a long time. And we know that the downturn in an economy really means we're dealing with mental health issues of people coping with changes in their lives that they just could not cope with other than with the use of substances. So these are all under the category of behavioral health, and that we need to deal with illnesses such as substance abuse, mental health, and the challenges that we all suffer or come across in our lives. So I think we're turning that corner. I think what we see from President Trump on down and to the side, that we're going to look at this differently. From CMS, from the Center on Disease Control, from physicians, we do see that differently. We just have to keep it that way. And the fact that we're approaching treating people with opioid abuse issues with other medications in order to wean or to have those folks kick that habit before they get out back into society, that revolving door you talked about, Representative Sheffield, that is something that is different than, we haven't done that since methadone and the original heroin epidemic. So I think we're in the right direction. We just have to keep moving in that direction.
Dr. Jones?
Yes, I think in general we are approaching this as a health issue and not criminalizing it. And we need to destigmatize this. It is substance use disorder is a mental health issue. It is a brain disease. It is complicated, and we need to support patients when they're suffering from this and see how we can help them once they end up down this road. And one thing is having support and resources from our addiction specialists, our addiction colleagues, and things such as medication-assisted treatment programs so that these patients have somewhere to go and be appropriately treated once we identify that they have developed a substance use disorder. So,
I would throw in about substance use disorder. One source I read said there's a 50% genetic component mixed in there. And I remember as a young physician in practice how some of the adult patients would have an alcohol problem, and then years later their kids would have an alcohol problem, and then perhaps later on there would be another alcohol problem. Well, now we can see that also because a drug is a drug is a drug, and abuse is abuse is abuse. Whether it's legal or illegal, addiction is a medical disease, and for far too long we've criminalized a medical disease. So fortunately, as my colleagues here have said, we're starting to change that to where we're going for treatment first.
You're so right. So you got, because imagine if somebody has mental illness in their family and the genetic predisposition to addiction, no matter what it is, that exacerbates whatever problem that already existed. I have bipolar disorder, and that's not I used to drink like a fish, y'all. And then when I got the proper medication, I don't drink anymore. Not because of the fact that I really don't want to or need to. And I think it's important for that to be understood. When I say that laughingly, but it's the truth. As soon as I got a handle on my depression as a part of my bipolar disorder, I just had no desire to self-medicate. And I think that's important when looking at this, because that's going to be a part of how we solve these problems, is looking at people's need to self-medicate, particularly in emotional circumstances in their families. It's going to be more difficult, obviously, with people who have predisposition to some form of addiction, whether it be alcohol or whatever substance that create altered states.
Dr. Jones, you touched on something that I want to come back to. You talked about this is a very complicated issue. And I think for a lot of people who, when we've been doing our reporting at the Tribune and otherwise, the big question is, how do you help someone who is at risk of addiction? So can you give some advice, some guidance on how a family member or a friend can help someone who might be at risk?
So I think as a provider treating patients, having a serious conversation before you even prescribe that first opioid medication, and engaging family members and close social support and involving them in that conversation even at the beginning before you even go down that path. One thing is entering into what we call an opioid agreement or a medication agreement, and part of that you outline the certain parameters of how I'm going to safely treat you with these dangerous medications, but also understanding that if I ever am concerned about a pattern of misuse and that you might be developing opioid use disorder, we have the right to reach out to family members, to talk to support people in their family and friends to try to gather ancillary information. And so as a family member or a friend, if you're concerned, it's okay to reach out to the patient's provider that's prescribing that medication, because they need to know that the family is concerned. And so obviously having a tough conversation with the patient as well, as a family member, talking to them about your concern. Certain patterns of misuse are using the medication despite an adverse event. So if a patient is pulled over for driving under the influence, for instance, and they continue to use that medication and they don't report that back to their doctor that's prescribing that medication, that's a sign, and so just reaching out and having those tough conversations. So.
Open up to the Dr. Representative Cole. You have nothing? You agree? Okay, that's what I like to hear.
Well, we always have to look out for changes in people's behavior. And clearly, if it's not noticeable, we have done some things on the state level that will hopefully prove to be effective, and that's convincing people to prescribe no more than that's needed so that there's not an oversupply of opioid or pain medications that are addictive sitting in the medicine cabinet, whether used by that person or somebody else that shouldn't be using them. And I think talking with family members is really important, because they usually notice when we're having issues that come from something other than just our normal activity. I hope that the prescription monitoring programs help in this regard, and even if it helps on one end, that it also helps knowing that somebody might have had a predisposition if someone comes across someone using heroin or other illegal drugs, which clearly we're going to have an uptick in use of as we clamp down on manufactured drugs that have been abused.
Yeah, I want to tag on again to another point he made. How many years have you been in the legislature?
27.
Okay, so he has seen more than most of us will ever see as far as legislations on this. But what he approached there is so many of our current heroin users turned to heroin after they were given their opioids, got addicted to the opioids, and their opioids got cut off. They still are an addict, having a need, wanting to fill that need, so they turn to illegal drugs. So this is, in one part, how the doctors brought this on ourselves. We were doing it for the right reasons, but we had the wrong outcome.
And it's so good to hear that, because it wakes us all up as patients and as people who are providers, that we should question and be aware of what we're doing to ourselves. I know that I was, for the manic side of the mood swings, I'm supposed to take Klonopin, but the doctor was very clear. Be careful, if you have a personality or some predisposition to addiction, you may not want to take this. And only take it if you think you need it or you're having these having mood swings. And therefore, I never took it because I knew that I did have issues where I had, self-medicated or used those drugs. The legal drug side of this is a challenge because of how it's ingested. So, Hep C, blood-borne illness, basically comes from the use of either through sexual contact, but mostly through use of intravenous drugs. HIV, intravenous drugs. Hep B, intravenous drugs. The uptick in other illnesses from intravenous drug use because of the shift to heroin and the increase in the use of heroin nationwide and here in Texas. And if they figure out how to put fentanyl in black tar heroin, and I'm sure they have so far, I'm sure they have, then it's even bigger of a problem of addiction to both heroin, but also more overdose that'll occur because of those drugs. And so we're into a health epidemic that is a byproduct of this primary health epidemic that we have with illegal drugs, and we're going to have to deal with that. And so that means in this coming session, we probably ought to talk about needle exchange again. Yes, we're going to have to talk about it because, and maybe not for some areas, but if we could at least do in some areas that would desire to do it, that we get there because again, the spread of HIV is the spread of death. If you have overdose in illegal drugs or any kind of drug and a death, then that's the same as having a death from Hep C or or from HIV or from problems with HIV.
I was going to say, Representative Sheffield, because I saw you giggle over there. So.
No, I wasn't laughing at you. I'm laughing with you because you remember the night, the first session we were there, 2013, and someone brought up a pilot program for a needle exchange. And his first session I'm there, I'm still green. And I'm sitting there, this is a great idea. This is a great idea. But I remember some of my colleagues walking around on the floor stating publicly to other colleagues, all we're doing is promoting addiction. We're helping them get their drugs easier, promoting addiction. And those of us with the medical background are saying, no, no, no. But we got very outvoted that night. So hopefully it will have a better reception this time. Because they've been proven to work.
Wait, follow-up question then. Is someone going to bring up a bill for
I had a bill.
You had a bill, okay.
And then the late Ruth Jones McClendon, Representative McClendon had a bill, and we worked together as well as with a bipartisan group of people. And I think we need to bring a bill along with this. That bill came through county affairs, and I chair county affairs, or at least until now, and hopefully we'll maybe continue. But I think it's very important. We can't deal with one part of this and not deal with the overall health impact of it. And I think it's clear that needle exchange programs work. We know that this is not something that it's just like using an opioid or opioid derivative to get people off of opioids. Sometimes we have to make the hard decisions. And we know that these are hard decisions, and they're being made all over the country. And so we're going to have to make that hard decision because in Texas, we won't see the hit. We won't see as much of the OxyContin challenges immediately as we'll see the direct to heroin challenges because these are social drugs. And the impact of economic downturns or whatever happens in our communities is going to affect people. So we said this was a rural issue.
Right.
Might have manifested among Anglo population. We already know that the uptick in communities of color of the use of heroin has already occurred.
So you mentioned something that I wanted to follow up on. So there are other states that are experiencing the opioid crisis or crisis with other drugs in a different way than Texas. We're not on par with West Virginia or Kentucky, Ohio. but we still have our own problems in Texas. And so for your colleagues who maybe are not all about needle exchange programs or programs of that nature, I mean, how do you amplify this conversation for them to make this a priority for them?
Well, and Doctor, you're going to have to help us because I think that the conundrum of pain management, because this first started with pill mills and the illegal sale of, or what became, pill mills, drug dealers, that because of OxyContin, but there's still a need for drugs like OxyContin. So we're going to have to make that clear, or some type of derivative of that for people who have pain. But they're going to have to know that this is real and it's their constituents. Mm-hmm. Just like we learned with methamphetamine. Somebody decided, just like a lot of people decided smoking cigarettes was a good way to lose weight. People decided smoking meth was a good way to lose weight or to keep from gaining weight. That these are still issues that people get into for various reasons. I would say that we shouldn't, in Texas, opioids are a big issue. Mm-hmm. But methamphetamine is probably a bigger issue. Mm-hmm. And how do we deal with this from both a treatment and a demand reduction standpoint? Because the demand is going to continue to exist because these are highly addictive drugs. I mean, these aren't drugs you try once and that's it. So right. How do we divert people from ever trying a drug of this type? And that's where it's important for the medical information to come to our colleagues. And the other is that once they do, don't blame them right. while we try to get them off. Mm-hmm. And that we deploy the money that we have from the federal government in the appropriate way to deal with the different types of addictions that there are. Because it's not just one. Mm-hmm. And I think that's extreme. If I can't emphasize mm-hmm. something enough, that's something that's extremely important that we've learned in the select committee. Drug addicts are drug addicts. Mm-hmm. They're going to go find it, whatever it may be. And so if you take them off OxyContin, even though it's a different drug, we all know that people use uppers and downers together. Mm-hmm. They don't just use one, they use both. Mm-hmm. Because if they get too low, they want to go up. They get too high, they want to go down.
We're just a few minutes away from Q&A. Start thinking about your questions. We have the mics on either side of the room. So in a few minutes, we'll start Q&A. Speaking of the work that the Select Committee did, you all just released your big report on Friday evening. I'll add as a reporter, it was Friday evening it was released. No, nothing wrong with that. But what the thing that of course stuck out to me is there are a lot of great seeming ideas that shows, it seems like y'all did a lot of work and studied this for quite some time, but it seems as if all the ideas y'all would want to implement or potentially recommend implementing are going to cost money. So with the legislative session where we have Hurricane Harvey recovery, you got to fund Medicaid, public school finance, how much of a funding priority is this actually going to be going into session? Representative Sheffield?
2 points there. Mm-hmm. Everything we can do to solve the drug crisis, opioid crisis, is the numerator. The common denominator is if we don't have enough inpatient and outpatient treatment slots available when we're trying to fix all these problems, we're not going to have a long-term fix of these problems. We have to have the treatment facilities first. That's medical insurance. Mm-hmm. And then my reading on other countries, for instance, there was a state, I think it's Washington State, on drug givebacks. Mm-hmm. They made the pharmaceutical companies pay for it. That's a great idea. They helped cause this problem. Let's let them help clean it up.
But in terms of the legislature's funding of these ideas, so not just Big Pharma, but also how the legislature is going to fund some of these ideas, how much of a funding priority will it be, given everything else y'all still need to fund too?
Well,
That-
first of all,
Yeah.
this is a nationwide problem.
Uh-huh.
And so Texas is going to do its part, and Texas has. So, for example, most people don't know, but we did approach and work on the methamphetamine challenge by providing more substance abuse treatment under Medicaid, and did that about 7 to 8 years ago. So we're not as heartless as people think. And so that means that substance abuse treatment under Medicaid exists for people who are eligible for Medicaid. The other issue is deploying the money we do have that comes from federal government appropriately. So with the additional dollars we're getting from both first the part that General Cornyn, Senator Cornyn did at the end of the Obama administration, along with the administration, those dollars are being deployed now in order to treat people with opioid addictions. We also have other money that comes from SAMHSA to treat those addictions. But it's also using new types of what I'll call treatment, and that's peer support. Peer support's a big deal because we were using peer support in substance abuse before we were using it in mental health. And with the expansion of peer support, that expands that assistance that is less expensive, sometimes free because it's volunteer, to help individuals through those circumstances. So I suspect that we'll see more money. And then, of course, I'm going to bring up the rainy day fund. It's raining for people with substance abuse problems. And we should use those dollars in the rainy day fund for that purpose. If we look at the other funding that we need to do, coming from Houston and along the Gulf Coast and other areas that have been through disasters, the rainy day fund is a good source of funding for dealing with those disasters. So that money exists now. And a lot of those challenges are challenges that are capital funded challenges that the rainy day fund is a good fund for. Plus, some other members and I will be proposing GEO bonds for Harvey, because I think that bonds are better in using the rainy day fund to pay those off, which will leave general revenue available to deal with these crisis issues in healthcare, both whether it's Medicaid in that sense, or particularly this circumstance. We have to be creative in our financing. But I looked at some numbers. We have $108 billion available in the rainy day fund. $108 billion. So we're not lacking for those dollars in terms of that circumstance. So the rainy day fund can be used for this to get us through the first parts of knocking down these issues in terms of the crisis level in diverting individuals from becoming addicted, and that's extremely important.
Okay. I was going to say.
Well, I think, as a pain specialist, what we can do as physicians is finding alternatives to opioids for better pain management and focusing on other treatments, non-pharmacologic treatments. I'm an interventional pain specialist, so what procedures can we do for chronic pain? Other types of pharmaceuticals that are coming down the pipeline that are either non-opioid or a derivative of an opioid that has less euphoria, and so the patients have a lower risk risk for abuse and misuse. So really focusing on better treatments for chronic pain. So that's what we need to focus on. How can we better treat chronic pain so we have more tools in our toolbox and we're not just reaching for opioids. I was a principal investigator for the treatment of complex regional pain syndrome, and we were utilizing bisphosphonates as a non-opioid therapy. So that's one example of what we're, our part as pain specialists is research and programs to have better treatments for pain other than just reaching for opioids.
So we'll get started on Q&A. Don't be shy. The mics, like I said, are on two opposite ends of the room. So keeping in mind, people, I know this is a personal issue. I know we have some intense feelings about this issue. However, we do not have time for everyone to share their individual stories. I respect your individual stories. However, I will cut you off if you start talking about your individual story, just because it would not be fair to other people in the room who have stories too and are not we don't have time to hear them. So, I'm politely asking right now that everyone really keep your questions tight, because we want to be able to make sure everyone here who wants to answer can answer the best way they can. And I encourage you to stay behind and talk to our panelists if you have something that needs a bit more clarification. So, no pressure.
I have my story printed out for you, and I'll talk to you after. Representative Coleman, you're one of my heroes. You're one of the people who gives me hope for the state of Texas. I lost my son. And he lived on the streets for 25 years because we failed to fund mental health in the state of Texas. And that's what I want to see. I want to see us
Do you have
commit.
a question, though?
Yes.
Okay.
How are we going to address the role of trauma in abuse through our police systems, in our criminalization, in what people go through that drives chronic mental illness and or chronic addiction? How are we going to address funding a mental health system that starts from school, that starts from young children and school mental health? How are we going to develop the commitment to our children to prevent?
Okay, so let's start with whichever question. You got a lot of questions, but they're good questions.
Well, first of all, I think you're right. We have failed people, and we started failing them tremendously in 2003 when dollars were cut out of the mental health system in Texas at a level that no one would have ever expected. And I think that we've done a good job, particularly this particular House, and over the last more than a couple of sessions, but particularly since 2013. And thanks to people like Representative Sheffield, as a member of the Appropriations Committee, Chairman Zerwas, Chairman Price, and others who said, no, we're going to treat this the way we need to treat it, and we're going to put money into a system of treating people with mental illness, both from a community perspective, also the plan for dealing with forensic beds that have taken up space from other people who need treatment. We have to continue that going into the next session of the legislature. And I believe that we will, and that's one of the reasons why I think it's important that we not roll back anything that we've done. That's the first line. And then we expand that community treatment of people with mental illness and substance use disorder, and looking at behavioral health as one thing. And the fact that Speaker Straus, and I'm sure that Speaker Bonin will continue to emphasize these things, that we take the work of the Select Committee on Mental Health, Select Committee on Substance Use Disorder, and the Select Committee on Mental Health, and continue to move those things down the road. And that's my objective. And also, I think trauma, from the perspective of looking at what happened in Santa Fe, or what happened in a church in Central Texas, and what happens to children that parents may have substance abuse problems, and then they end up in foster care. As you know, 2/3 of the children in foster care are there because of some connection with substance use disorder. That these are the types of things that we continue to work on. I'm confident that at least I could be confident from the House perspective that we will not abandon you or people like your son or others from getting to that place where they need to be. And I'm confident that the House is committed to that.
Great. Thank you for your questions. Next, over here.
Hello, my name is Joshua. To the question of, you would ask the doctor, the anesthesiologist, what are they doing as far as like listening to patients and such? I have a question for the politician, and the same question, what are politicians doing to listen to those with experience? I won't share my story, but I've been in the ER 80 times, 70 times in the last 3 years from my whole neck is fused, and I have a wealth of experience in dealing with these opioids. And part of the reason why I came here was to find an avenue on how I can get more understanding and hear a voice on my experience. And so I'm curious with politicians, why aren't politicians listening and using the story of those who have the experience to go to Congress and address these issues? And to the doctor, I'll connect with you later. I'd like to find out how I can speak with you and share my story and learn from my experiences.
Thank you.
First off, Chairman Coleman here has probably forgotten more about mental health than the rest of us will ever learn in our career in the legislature, because he's been one of the advocates there for decades. Now, to give you a look at how the legislature works for those who aren't front and center on this type of issue, it's not part of their background, it's not part of their training, not part of their life. Sadly, for some of them, headlines get their attention, and headlines drive their votes. So now that the opioid crisis is making the headlines, it's getting their attention a lot more than it would have the night we were talking about a pilot program for needle exchange. So the way y'all have an influence there is you show up at these meetings where these people are speaking or debating and saying, I'm so-and-so, tell me your feeling on this issue, yes or no, this issue, yes or no. And focus groups take that and run with it through social media and other media about where that candidate stands on this issue. And that will have more impact than you think it will at this point.
Great. Okay, great. Yes.
Yeah. Hello, I am Dylan. I'm a nursing student here. I want to work in emergency services. And so in regards to the companies and all that stuff, I know that the class action lawsuit in Ohio has been brought against the Sackler family, who are the ones that, kind of peddle a lot, and they came up with oxycodone, or probably pronounced that wrong. But so in a resolution for a case with such a wide scope as that one, what would justice look like to you guys? I know that's kind of vague, but.
Vague is good.
Very good. Justice. If there's a criminal case brought, jail time. Because when you kill a lot of people, we believe in jail for murder. And that's exactly what this was, because they knew. See, if they didn't know, it'd be a different story. If it was an accident, they knew. And that they have to put out a lot of money. And I mean a lot of money.
Yeah, the thing was like, they took all the money from their pharmaceutical company and brought it to the family.
Well, we need to get whatever money we can get from them.
Yeah.
Just like we did with the tobacco settlements, from killing a lot of people with the sale of tobacco, even though it's still legal. So we did a good job by using those tobacco settlements in those lawsuits brought by the state and brought by counties in order to serve people who were affected or would be affected by tobacco use. And I think we could do the same thing in these class action lawsuits, and brought by individuals, but also lawsuits should be brought by states and others for the cost of this to the society and to our different programs that we've had to spend money on to help individuals that have been addicted. And that would be my thought. We have a model for it, I guess is what I'm trying to say, for the use of those dollars. I was around when we did the tobacco, I've been around when we did the tobacco lawsuits, and they were very effective in terms of putting money into prevention of smoking and smoking cessation and treatment of people with smoking-related diseases.
Great, thank you.
The next person, though, for questions is, okay. Next, over here.
Thank you. My name
You said million? Oh, that's a small amount. We did billions in the tobacco market.
Okay. Yes, ma'am.
My name is Heather. There are 33 states now in the U.S. that allow access to medical cannabis. Last legislative session, there was a bill introduced of which both of y'all were co-signers, and I thank you for that. Wondering, we see reports published by the Journal of American Medical Association showing that not only a decline in the number of the instances of prescriptions for painkillers, but also in opiate overdose deaths, declining 25% in those states. Can you all speak to the Compassionate Use Act, making it more inclusive so that cannabis can be an alternative for those who want to use it instead of opiates?
Dr. Jones?
I don't know if I can really speak on the Compassionate Use Act or the legal implications of compassionate use of cannabis. What I can speak on is just my exposure and my understanding of the literature and the science that we have. And we do recognize as pain specialists that there are analgesic properties to cannabis. What we have yet to show and illustrate, and I mean, this is a very recent review, it's a systematic review, a Cochrane review, 2017, looking at all of the literature out there, is what is an appropriate dose, how do you deliver it, is it safe? And so right now, I don't think we have the science to really recommend cannabis as a safe or therapeutic substance for chronic pain. The science isn't there. And that was a very recent review looking at all of the studies out there. So really, again, getting back to what we can do as pain specialists, we need to keep researching, we need to keep looking at substances and pharmaceuticals that can be appropriate and helpful in the treatment of chronic pain. So.
And speaking as a physician in the legislature, there's always a feeling amongst legislatures of voting on something that's a feel-good bill. Makes you feel good, it sounds good to the people back home. But in the medical cannabis, if we take our time to go slowly and get it correct with the proper testing and trials, then we will get a better outcome if and when it starts becoming used, rather than, and I hate to sound like I'm being a wet blanket on just saying, okay, we're going to throw it out there and anybody can use it for anything just because we want them to. We need the studies to best determine what my colleague determined, dosage, route, concentration. That takes some time, but it takes studies.
And we've made progress in that regard with the cannabinoid oils that are going through those same, as we're allowing their use, going through those same protocols with the type of dosage that is necessary, using the cannabis as a medicine and deploying it as a medicine. And I think that's extremely important. Our advantage is going to be that other states have taken some leaps that we haven't, and they'll be able to do that type of research in conjunction with our researchers here in Texas.
I'm getting the signal that we don't have any more time for questions, but please, a round of applause for our great panel. And for those who did have questions, I encourage you to come up after, and we'll be here. Thank you so much for coming. We appreciate it.